We are going to go ahead and get started with our presentation today. I'm Georgia Davis. Nice to see everyone both in person and virtually here. So it's really my great pleasure today to welcome Dr. Ashby Walker, who's joining us from the University of Florida today to speak about the use of technology in caring for patients with diabetes in underserved communities. Today we'll have Dr. Walker give her talk, and we'll try to end a little bit early so we save a few minutes for questions. It's really fun to have her here. So she actually finished her sociology training here at Emory and is just back here now. I have a cheat sheet for all of her titles here. So Dr. Walker is actually, she is the Director of the Health Equity Initiatives at the University of Florida Diabetes Institute, and also an elected member of the American Diabetes Association National Health Disparities Committee. She has taken on now a role as the Director of Care Services at Blue Circle Health, which is a nonprofit diabetes clinic that really focuses on bringing medical care to people living with type 1 diabetes in under-resourced communities. We are excited. Dr. Walker is an incredible leader and patient advocate for patients living with diabetes, and is focused on reducing those care disparities that we face a lot of times. And it's really nice to have you here today. So welcome.
Thank you so much. It is really a pleasure to be here. And I want to start just with a thank you for the invitation to be here, and a thank you especially to Georgia and Francisco for the work that went into bringing me here. It is special to be at Emory because I did my undergraduate work at Emory as well as my PhD. As an undergraduate, I had a needs-based scholarship. So to come back as a speaker, this is just a really neat career moment. So I'm going to share with you today about Project Echo Diabetes. And I also want, as has been mentioned, time for interaction and questions. So I'm going to try to get through this talk so we have enough time to just have some dialogue. In terms of my disclosures, I don't have any disclosures. I think the clicker's going to work for me. Oh, here we go. I don't have any conflicts of interest to disclose specific to the presentation today. Funding for the program that I'm going to talk about today comes from the Helmsley Charitable Trust. And so I want to say from the outset the gratitude that we have as a team that we've been able to have funding to do the work that we're doing with Echo Diabetes. I do serve as an elected member of the American Diabetes Association's National Health Disparities Committee. And I also want to say there's two different slides that do have images of people on them. And I have permission to use those images in the talk today. In terms of the objectives, I'm going to touch base about the Project Echo model first, just to give you an overview of Project Echo. This approach to reducing health disparities came out of the University of New Mexico. And so just to give kind of the broad context of where this model comes from, we're going to talk about the Project Echo model, and then we're going to specifically look at the Echo Diabetes program that's currently in progress. We are in the thrust of a stepped wedge design, evaluating the impact of this program. And so when I talk about the research, I can give you a little snippet of what we're seeing, but we're really at the crux right now of our patient provider health center level outcomes. So I'll show you a preview of the data, but we're not done with analysis yet. And then also talk about future directions for the promotion of health equity and diabetes care. I want to say from the outset that the Project Echo Diabetes program is a multidisciplinary group. You hear a lot about team science, and I would posit that with the Echo Diabetes program, we have had the very best of teams that are multidisciplinary, really working and collaborating together. The University of Florida and Stanford University received a grant from the Helmsley Charitable Trust, initially to do a pilot in type 1 diabetes, and it's now expanded to type 1 and type 2. So at the University of Florida, we have multiple PIs. So I am PI as a medical sociologist, along with Dr. Michael Haller, who's chief of pediatric endocrinology. And then at Stanford University, we have Dr. David Ma, who is both a pediatric endocrinologist and an epidemiologist. And we also have Dr. Ananta Abdallah and Dr. Rayhan Law. So we have a really nice leadership group. I've loved collaborating with everyone, but beyond our leadership group, we have a number of people who work together to make echo diabetes possible, because this is an implementation program that takes a lot of different people in terms of the provider education. We have certified diabetes educators, nurse practitioners, clinical health psychologists. We also have a senior biostatistician, Dr. Matthew Gurka, who I want to acknowledge as he guides all of our analysis related to evaluation. And we couldn't do this work without all of our teams really collaborating closely and for a number of years now. So when we talk about the ECHO program and what was the reason why we wanted to form the ECHO program, just a basic touch base on outcomes for people living with diabetes in the United States. If you look at HEDIS data, and this is for both people with type 1 and type 2 diabetes, so this is not distinguishing diabetes type, we know that there's a significant portion of people living with diabetes in the United States who don't reach the optimal levels of health that we would want to see. And so HbA1c is a really important target in how we evaluate diabetes, but I want to say it's certainly not the most important or only outcome in diabetes management and quality of life. But if you look at these data, the big picture is many people living with diabetes are above 9% HbA1c, which is not ideal for a number of different reasons. But if you look more specifically, both in type 1 and type 2 diabetes, there are profound health disparities in terms of getting a little bit more granular than that big panoramic. So in type 1 diabetes, we see health disparities based on socioeconomic status. This happens very early in childhood for children diagnosed with type 1 diabetes. From lower SES or socioeconomic status households, we see greater risk for hospitalization for very serious diabetes related complications like DKA. We see higher levels of HbA1c, and those SES differences in type 1 persist across the lifespan. We also have disparities in type 1 based on race and ethnicity that cannot be explained away by SES. And so we see differences, for example, in utilization of technologies like CGMs and pumps based on race and ethnicity. And this is, again, irregardless of SES. So some people kind of, I think, explain disparities away as saying this is just about SES, and it's actually not. And there's been a number of studies that show even for very affluent, highly educated, non-Hispanic Black communities living with type 1 diabetes, there's a higher risk for morbidity and mortality, and there's also underutilization of those technologies that I referred to before. In type 2 diabetes, there are profound health disparities as well. When you look at who is most at risk for developing type 2 diabetes, certain groups face disproportionate risk. Non-Hispanic Black, Hispanic, and American Indian communities face elevated risk for developing type 2. And then again, when we look at disease, morbidity, and mortality across the lifespan, both SES and race and ethnicity matter in diabetes outcomes. So why do we have those disparities? And there are a myriad of reasons and a lot of different barriers that underserved communities face in achieving optimal health. But one of the things that we could focus on, if you think of all of the different targeted interventions that could be there, it's recommended that people living with diabetes see an endocrinologist for care. And in fact, it's recommended that they see an endocrinologist 4 times a year. But there's a growing body of evidence that in endocrinology, and the question becomes why. And there's not one easy answer. We know for people living in rural areas that distance and proximity to a provider might be a really the teams I've been able to work with to do this research, that in identifying barriers for utilization of endocrinology care, we also know that sometimes people might not want to go see an endocrinologist for reasons where they feel like they are judged, They feel like they're in trouble when they go. So they might have access to an endocrinologist, but not see the value of the visit for their health. And that's a very different barrier than distance. So we need to understand all of those barriers to be able to address underutilization of endocrinology. We also know that for working poor communities, taking time off of work to go see an endocrinologist for a preventative care visit might be prohibitive, just in terms of wages lost. And again, beyond distance, we have to think that someone might have access but not utilize, and kind of differentiating these concepts of access versus utilization. So there is an underutilization of endocrinology. And the Project ECHO model that we are using, that we are part of, which is really now a global movement, recognizes that if you want to reduce health disparities for communities who need those types of targeted interventions, many from underserved communities rely on a primary care provider more than they do a subspecialist to receive their care. And so the Project ECHO model really was founded on this principle that if you want to reduce health disparities, you have to engage primary care providers in those efforts. So the Project ECHO model was started at the University of New Mexico. Dr. Aurora is really known as the person that started this. And the first iteration of Project ECHO was for hepatitis C. And so in the state of New Mexico, the challenge he saw was there are people in these rural underserved areas that don't see subspecialists, but they do see primary care providers. So he developed a teleeducation program where providers could train providers and empower the providers in the primary care setting to know how to treat and manage hepatitis C. So that was kind of the first iteration of Project ECHO. The idea of this is that you democratize knowledge. That's what you'll hear if you go on their website, if you go to their trainings. They want to move the knowledge of the subspecialist to primary care through this kind of education program. And to be clear, a lot of people will say Project ECHO is telemedicine, and specifically it's not telemedicine in the way we traditionally think about telemedicine, which would be an individual provider rendering care to another individual via a virtual technology like Skype or Zoom. This is really a provider to provider training program where you have a group of subspecialists training primary care providers in how to kind of share that knowledge so that if someone is relying on the primary care provider for care, the primary care provider knows what to do when they're empowered to do that. And the idea behind Project ECHO is that you amplify the benefit of this far beyond a one-on-one telemedicine relationship, because you're training hundreds of providers, potentially that see hundreds and hundreds of patients. So the heart and soul of anyone doing a Project ECHO program, and so we're going to talk about our ECHO diabetes program, you have what's called a hub team. This is the language of Project ECHO. And then you have spokes. The spokes are your PCPs and their health centers. The hub is the multidisciplinary people who focus on some area of specialty care. So for endocrinology and diabetes, our hub team, what that looks like, you have a pediatric endocrinologist, an adult endocrinologist, a clinical health psychologist that specifically focuses on behavioral health issues related to living with diabetes, social work, you have pharmacy specialists at the table, you have certified diabetes educators, but all of these people come together to do this teleeducation. It's a 1-hour session. The providers receive CME for watching that 1-hour session. The first 30 minutes is a learning module that's developed by one of those experts on the team. And then the second 30 minutes is a de-identified case presentation that comes from the health center. And this is what's called an all teach, all learn model. It's really powerful to watch. And if at the end of today, if you're curious what an ECHO session is like, we have one tomorrow, and I will make sure to send you the link so you could just kind of watch this happen. But it's really moving away from the idea that the hub team is the expert and they know what to do and they're going to tell the PCPs what to do. The idea is that you want the PCP to weigh in first. So you'll see when it comes to the case presentation, we really turn to our community partners first and say, well, what would you do in this case? And the people who have the subspecialty knowledge kind of pull back and really try to see what the group has to say first before case presentation ends and at the end. In terms of the Project Echo model, this model is being used all over the United States and now globally. All of those little dots are probably, there's an even more updated map than this, so there would be more red dots. So this is, and all of the different programs, whether they're focused on cardiovascular health, whether they're focused on cancer, COVID, there was a big COVID echo program actually in nursing homes. The idea is that you're trying to reduce disparate outcomes in lots of different types of chronic and infectious diseases. So when we were able to do our own iteration of our Project Echo diabetes program, we as a team wanted to first engage in a needs assessment. And I don't know if I have public health students in here right now, but this is part of what you learn, and it's actually really important because you have to understand what you're going to build before you build it. And so what we did for our needs assessment, number one, we did surveys with primary care providers across the state of California and Florida to really try to gauge where they were with their diabetes knowledge and confidence and being able to deliver this type of care and to understand what type of diabetes care they were doing in the primary care setting. We also did focus groups with, I would say, the most important group of stakeholders, people living with type 1 diabetes that were from underserved communities. We really intentionally worked to recruit people from underserved communities that are often not represented in studies that recruit from endocrinology clinics. For example, we want to talk to people not going to endocrinologists. And so we did the focus groups to truly understand from the real experts what are the barriers, especially for going to access the endocrinologist and for accessing and using technologies like CGMs. We finally wanted to develop some way of recruiting primary care providers into our ECHO program that was systematic and somebody else could replicate. We went to the trainings at the University of New Mexico and it was amazing, and you learn all about how to do the teleeducation part. But the practical part of implementing this is like, how do you start recruiting primary care providers into your program? That's in California and Florida are very large states. You know, how are we going to do this in a way where we reach underserved communities? And again, where we're reaching the communities that we want to reach. And so we used the expertise of an epidemiologist who's a spatial geographer. And there was work around the neighborhood deprivation index and provider geocoding to try to locate areas of Florida and California where there was a low density of endocrinologists, but high NDI scores. So the higher the neighborhood deprivation index, the greater the risk for negative health outcomes. And really, we focused on federally qualified healthcare facilities in our recruitment of PCPs. And I'm going to talk about why in a minute, but these were parts of what we went through before we implemented our program. We've been able to publish really all of our work from our needs assessment. One of the big takeaways from the surveys with the PCPs is, number one, they are doing diabetes care. I collaborate with a number of wonderful endocrinologists who, if I could see the screen right now, I have a feeling a few of them are on the phone, but there is a pervasive belief, I think, among endocrinologists that especially children are seen for care by endocrinologists who live with type 1 diabetes. And actually that doesn't align with reality. So there are a number of even children living with diabetes that are relying on primary care providers for their care. When we asked the primary care providers about this, the vast majority had provided an insulin prescription for somebody living with diabetes and acknowledged they were the only person that person could rely on to get insulin. But what we found from those surveys is that there was very low confidence and knowledge in diabetes technologies like continuous glucose monitors and insulin pumps. And if you remember from the beginning of the presentation, we see these disparities in use of these technologies that have benefit for quality of life, for understanding how to thrive. But if we are not including primary care providers then in training about CGMs and pumps, we're missing a very significant group of people that could impact health disparities and promote health equity through technologies like this in their setting. So we knew, I want to go back one slide quickly, we knew when we developed our curriculum we needed to focus on just explaining what CGMs are to the primary care providers. In fact, part of our training and onboarding of new PCPs, they receive a sensor and they have to insert it and wear it and download the data on their phone so they can make meaningful use out of that then with somebody else. So we did learn a lot from the surveys that impacted how we implemented our education program. From the focus groups that we conducted, I love being part of this group, this P30 cohort, especially because I've seen the social ecological model talked about in several different presentations. And I am a faculty in the College of Public Health at UF, and we really push this so much, but it's so helpful when you're trying to understand how multiple layers of influence impact health outcomes. And then how do we target an intervention that is at not just one level, but is hitting at different of these levels. So when we did the focus groups, we asked people living with type 1 who were from underserved communities, what was the greatest barrier to utilizing endocrinology and also utilizing technologies? We heard a lot of different answers, and I just want to show you, we use the social ecological model in our write-up that we published in Diabetes Care. We definitely heard that cost was a barrier, so that's where a policy can impact an individual person's health. If there is a payer that won't pay, or somebody doesn't have insurance to have access, that is a policy level or societal barrier that really impacts our ability to reduce health disparities. But more than that, I've circled interpersonal, because one of our biggest takeaways from this research is that the barrier that got talked about the most in terms of endocrinology and technology was something that was happening in interactions with endocrinologists, where the person living with type 1 felt misunderstood, felt shame, felt a sense of being judged. It was described as going to the principal's office and not in a positive way. And so a lot of the people living with type 1 had stopped going to see an endocrinologist because they didn't see it as useful for improving their health. So while we saw barriers at a lot of different levels, the article that we published pulled this point out, that we also have to consider implicit bias and other things that can happen in a clinical setting as a barrier that we have to target as well. In terms of how we did recruit what we call our spokes, we focused on federally qualified healthcare facilities across California and Florida. If you're not familiar with what an FQHC is, 30 million people in the United States get their healthcare at an FQHC. By definitions, FQHCs cannot turn anybody away for care based on their insurance status. They have to have a sliding scale for payment. They have to be within a walkable distance of the community they serve. Their providers have to have the same demographics of the communities they serve. So FQHCs were a strategic partner for us in trying to reach underserved communities through providers who serve underserved communities at the FQHC setting. So in Florida, we're working with 18 different health centers. They have 62 different locations, and in California, they have 23 different spokes, is what we call the health centers, with 45 different clinic locations. And collectively throughout California and Florida, we are able to work with providers and patients. And I'm going to talk about how we have patient engagement that are really both living with type 1 and type 2. Our focus is on people with type 2 that have multiple daily injections of insulin. Has kind of been our focus for our type 2 population, but we are serving very racially diverse communities who are typically low SES. So for the echo diabetes model that we developed after our needs assessment, we provide that kind of bread and butter of the Project Echo model, the provider education. We do our tele-education sessions. We also do real-time support with the spokes, and this is typical of a Project Echo program. So outside of that 1 hour of training, if a provider in a PCP in an FQHC setting has a person living with diabetes and they don't know what to do, that's diabetes specific, they can call on our endocrinologist. They can call on our clinical health psychologist if it's something specific to behavioral health. They literally have the cell phone numbers. We were a little nervous when we started the program because we didn't know how much people were going to access this to have, you know, the endocrinologist and everyone just giving out their cell phone numbers, but it's worked and it hasn't overwhelmed anyone. But it's also been a really important way to get someone living with diabetes an answer to the PCP immediately, rather than there having to be a referral and perhaps a very long time passing before they could go see an endocrinologist themselves. We also utilize what we call diabetes support coaches. And so the diabetes support coach implementation part of our Project Echo diabetes program is not typical. And I want to say that. So if you looked at Project Echo programs and how they're happening all over the world, a lot of it depends on funding and how much money someone has, but we had the funding to implement a patient level intervention. So if you think about the Project Echo model, this is a provider intervention, right? You're trying to train providers. But for many of us on the leadership group, we felt this benefit would be maximized for people if we had a person level intervention. And so for that, we use diabetes support coaches, and I'm going to talk more about that, but it's a combination of a community health worker and someone who lives with diabetes. So it's like peer support plus community health worker. And then all of these folks have access to an online repository of diabetes education materials, learning modules. All of our Echo sessions are recorded and online so the providers can access them afterwards, or if their peers can't come to one, they can actually see it online. So in terms of our curriculum, I have to just thank and give a shout out to the amazing multidisciplinary team that leads this curriculum. I have been participating in the Echo clinics for a long time, and I learn something new every time we're in a session. But again, this is not just delivered by endocrinologists. We have people like Dr. Sarah Weston, who's a clinical health psychologist who focuses on diabetes burnout and things that providers need to understand about the psychosocial aspects of living with diabetes. We have entire sessions on what to do when cost is a barrier for insulin, for getting different types of devices. But this is a curriculum that spans type 1 and type 2. The community watching gets CME, CNE, MOC part 2 and 4, and this has been a big learning curve for me. And again, I want to thank Eleni, who's a nurse practitioner, who's really spearheaded getting all of these credits available for the providers each session. So I talked about diabetes support coaches, and I want to get through my talk quickly enough so we have time to talk, but just to give you a quick why did we, put this part in our intervention? In my career, I have focused on peer support as a mechanism of reducing health disparities. So I'm thinking now how long ago this was, probably over a decade ago. I received a small pilot award that allowed us to do an RCT where we paired college students at the University of Florida who live with type 1 with adolescents seen for care in our endocrinology clinics that were publicly insured. At the time we implemented this, there were no programs in place to really try to address the profound health disparities we saw in adolescents living with type 1 who were publicly insured. So this was an RCT, and we did have randomization of the adolescents either to a treatment or control group. And just, again, to give you just a little bit of the why, what we saw with this program, not just in terms of improvement in A1C, and I want to say the benefit for the college students was one of the takeaways from that RCT, because the college students participating had an improvement in their health outcomes. They felt less isolated. After on a huge college campus, they knew 30 other people also living with type 1 and got to participate in this program. So there was definitely benefit to the adolescents assigned to a mentor, as well as for the mentor group. But what I want to call your attention to that really gave us hope for this as being an avenue for future studies, which it became an Echo, was that adolescents who were randomized to have a mentor scored much higher after the intervention on what's called the Children's Hope Scale. So their hope for their own future went up after they were able to meet somebody who also lived with type 1 and to share those experiences. And so that goes beyond HbA1c, I think, in terms of the power that people living with diabetes can have for communities living with diabetes. So in the Echo program, we implemented diabetes support coaches. These are people, and it's not just type 1 anymore, because I said in the beginning, this was a pilot initially for type 1 and we've expanded to type 2. But it's someone who has a personal connection, lives with type 1 or type 2 diabetes. They organize social gatherings. They serve really as a liaison between the person living with diabetes and the FQHC PCPs that are participating in ECHO. So some really powerful stories I could share, but the coaches all receive standard training, whether they're in California or Florida. They receive several levels of certification. They participate in the University of California at San Francisco's Health Coach certification in primary care settings, which really focuses on social determinants of health. They also receive a number of other certifications. They can't give direct medical advice. And for an implementation program this large, that is tricky to oversee and assure your IRB that nobody's giving direct medical advice in 40 different health centers. But we have been able to implement the diabetes support coaches in a way that we hear high levels of satisfaction from our health centers, from people that are receiving these services, as well as from the coaches. I have permission to share this, but I just want to show you some of the wonderful, amazing people who are serving as health coaches for us. In the ECHO program, we have recently transitioned many of them into a new program called Blue Circle Health, but I just want to acknowledge that when you're wanting to work with underserved communities and people talk about trust, we could not have done the work we're doing without people that were local from the community, that both understood the community and also understood diabetes. They have a legitimacy with the community that we could never have. And so they have taught us some of the most important and valuable things in this program. I'm just showing here, I'm going to flip through this quickly. That's the training that they all receive across both states. They organize social events. They also speak languages of the communities that we're serving. So our coaches, depending on where they are, speak Spanish, or Creole. We make sure to translate the resource guides that are developed for diabetes into Spanish and Creole where needed. And they also do social events at times and places that make sense for working poor communities and make sure that people can get there at no cost. So we are in the process of evaluating our ECHO diabetes program. If you look at the Project ECHO model, and I showed you the map of the globe and there's all those little dots, Project ECHO is being implemented in a lot of different ways, and it's being evaluated in a lot of different ways. I have a wonderful fellow, Jennifer High, if you're on the call right now, I have a feeling she is. She has just completed a scoping review of all evaluations that people have used to try to see if their ECHO program was successful. And she's going to be submitting that for publication soon, but you can imagine the ways that people have evaluated are very, very different. And so most evaluations of Project ECHO involve provider knowledge and confidence, because this is that provider level intervention. For our program though, we wanted to really think about how to do this systematically, rigorously. And so I also want to thank Dr. Matthew Gurka, because he guides all of this, but he designed a stepped wedge design where instead of just focusing on provider level outcomes, we wanted to see if patient level outcomes changed at the participating health centers. When you look at the promise of the Project ECHO model, the promise that it reduces is that it reduces health disparities in people. And so that's not the same as empowering providers. And so we wanted to know, does this actually impact people living with diabetes in a positive way? And then also what we call spoke level outcomes, which is an aggregate look at a health center. Does this health center's participation in this learning outcome program really do much to improve outcomes for people living with diabetes? Does it reduce hospitalizations for complications like DKA? So this was a massive undertaking. If you can imagine doing DUAs with all of the different FQHCs across both states, the IRBs, but we have done it with the help of amazing teams. We are at the point in our stepped wedge design now where we're getting the last round of aggregate data. But in terms of how we did the stepped wedge design, if you're not familiar with this as a design, everybody gets the treatment in a stepped wedge design, but it is phased in. So there was a randomization plan for the health centers where they started in 6-month intervals. And there was a baseline period where outcomes were evaluated before we implemented the intervention. And so here I have a list of all of the health centers that were part of the stepped wedge design, both in Florida and California. And if you look in parentheses, you can just get an idea for how many patients with type 1 and type 2 who are on multiple daily injections of insulin that are seen for care at that health center. Just to give you a little glimpse, and I want to look at my clock because I know there's a class in here we need to get out at 55 after, and then we want some time to talk. But the providers participating, we have been doing surveys with them every 6 months, gauging their knowledge and confidence in diabetes care and management, getting feedback on our sessions and how we can improve them. We also, I just wanted to share some of just a little ones, because we haven't published these findings. We're not finished completely with aggregate. So I'm just going to caution that this is very preliminary and this is just what we see right now. But to reiterate the point that not everybody with diabetes goes to see an endocrinologist, when we ask the providers the question, I refer patients with insulin requiring diabetes 18 and older to an endocrinologist for their diabetes care, almost 40% said they never do that at baseline. So that means there's a significant group of primary care providers who don't refer people living with diabetes. And also, when we said in the past year, I wrote an insulin prescription for an adult with diabetes, 97% said they had done that. So they are doing diabetes care. There's still a group of people who I don't think fully grasp this, that there's people with diabetes that never go see an endocrinologist, but there is a significant group of people who don't go see an endocrinologist. In terms of patients who were recruited for the surveys, I'm really thankful again to this enormous team who's made this possible, but in order to engage the communities that we wanted to engage that are traditionally left out of studies, a lot of times, especially on type 1 diabetes, where recruitment only happens in endocrinology. I do want to just thank again the teams that made this happen, and we had to be very strategic in the recruitment efforts for this research. But we do have a cohort of about 347 people living with both type 1 and type 2 who are on multiple daily injections of insulin across Florida and California. There are differences that I want to show you between California and Florida, just at the highest level at baseline that we see that we would expect. I think because of a lack of Medicaid expansion in Florida, to be quite frank, and I'll show you that slide. But if you look at baseline diabetes management characteristics, you see here overall the people who completed surveys, very small percentage who are actually using insulin pumps and not a large percentage that are using CGM. So still a lot of work to be done in the FQHC setting to allow people to engage with these technologies. But some of the differences that we're seeing even at baseline within this cohort where everybody is really from lower SES backgrounds. People who are publicly insured have the highest HbA1c, and it's statistically significant. And then also within the FQHC setting, non-Hispanic, Black, and Hispanic individuals living with type 1 and type 2 have statistically significantly higher HbA1c levels. We see between California and Florida differences in technology use. So there's still a long way to go in both states, but Florida has an underutilization of diabetes technologies like CGMs. And again, there's policy level differences between the two states that probably make it more difficult in Florida to get a CGM or a pump because of our lack of Medicaid expansion. But I just want to draw attention here too, when we asked the people living with diabetes who had seen an endocrinologist for routine care in the last year, about half had not seen an endocrinologist in the last year. So again, to kind of corroborate that point, that there are people living with diabetes that aren't going to see an endocrinologist, and a very small percentage had seen a behavioral health specialist for their needs related to diabetes, which is another critical need. So in terms of where we are in our timeline, we have completed data collection now at the patient level. We have one more kind of submission coming to us from the health centers for the aggregate data needs for this, and then it's going to be writing up our findings and sharing what we learned, really in an effort to be fully transparent about how we evaluated this program, what worked, what didn't work, and also to hope spur a larger conversation with people engaging in Project ECHO programs about evaluation, because these programs are being evaluated very, very differently. So just in conclusion, Project ECHO Diabetes can help promote health equity by the PCP empowerment, and also through growing social network support and community capacity through our diabetes support coaches. Just a few takeaways: primary care providers in the FQHC setting are really important partners in the promotion of health equity. I know some of our colleagues on this P30 work in FQHCs and already are in this space doing really important work. Community health workers can augment virtual delivery models, the diabetes support coaches, because they're actually physically in the communities and at the FQHCs have done invaluable work for us. And finally, underserved communities need to be represented in the work that we do. I want to just say, in terms of where we're going with ECHO Diabetes, I can share the PowerPoint publications slide afterwards, Princess, and you can make that available. But I want to just also say the Helmsley Charitable Trust has now dedicated a significant amount of funding to start what is called Blue Circle Health. Blue Circle Health is a nonprofit that is going to eradicate barriers for people living with type 1 diabetes in terms of getting the care, the technology that people need, and they are eradicating cost. And so there was a large initial grant to make Blue Circle Health possible. And the idea, coaching was one of the first services provided, and many of the coaches from ECHO transitioned over. We're focusing on FQHCs with Blue Circle Health, but through Blue Circle Health, people living with type 1 are going to be able to receive social work services, insurance navigation, behavioral health, endocrinology at no cost. And there's no hidden anything here. This is at no cost to the person and no cost to the health center. So again, I just want to thank the Helmsley Charitable Trust for their incredible generosity, and not just what they provided through ECHO Diabetes, but their continuing commitment to underserved communities. And with that, I can stop and we can take questions and have some dialogue now, hopefully.
Ashby, there is a question in the chat already. How did you exactly define the patients with low SES?
By focusing on federally qualified healthcare centers, you are by definition focusing on lower SES communities because of what it takes to qualify as an FQHC.
Good question. So during those ECHO meetings where the primary providers and the hub team are discussing things, do you think that getting the input and recommendations from the primary care provider first changes the potential recommendations from the hub team? And I think my specific question is surrounding, the community or patient factors that provider might be able to identify more readily than maybe the hub team. Do you think that has been something we've seen?
I definitely think that the PCP and the FQHC setting has knowledge that contributes collectively to this all teach, all learn, especially I would say related to social determinants of health. So there might be something that we just see as standard of care that they can identify a barrier like that we might not think of, that is more specific to the communities they serve because they know the community really well. So I really would encourage, I'm not just saying this, anyone who wants to just watch a session, we have a session tomorrow. I can start sending emails out to anyone in our core who would like to attend, but it is kind of atypical, I think, in traditional medicine, where you usually have an expert rendering an expert opinion, and we really try, in the spirit of the Project ECHO ethos, it's supposed to be that everybody has knowledge to contribute. Now, that said, there have been times that recommendations, like somebody says something that's like, wow, that would not be the best thing to do. And I think what's really beautiful is the hub team gently will say, well, that is one way we could do it, but probably what would be best in this situation, or what the ADA standards of care recommend is X. So it also isn't like so open that we aren't guided back to the core best practices that we're trying to disseminate. And then after the session, the kind of recommendations of the collective hub team are emailed out to everyone. So there's a consensus on what would be the best approach to whatever the case that was presented.
Great lecture, Ashby, that was really awesome. I had a question on closing additional gaps. So you are addressing rurality, you're doing training the providers, you're doing peer support, they're getting CGM. I can imagine that there's people that still don't achieve goals besides all those things.
Yeah.
So I'm wondering beyond socioeconomic factors and insurance access and all of those things, are there any other things that you think that work needs to be done? I don't know, maybe in behavior or other things.
I would start at the policy level. So I think when we think about something, I know you said cost is a barrier, but I want to reiterate how important policies are in impacting some of these disparities. And so if somebody can't have access, it does not, like, you're already removing the ability to work on anything else after that. So just a little example, in FQHCs, the FQHC has access to a program called 340B, which provides insulin to people at a discounted rate because it's seen as a life-saving drug. If we could advocate for policy change in 340B related to CGMs also being offered at discounted prices to FQHCs, the impact that policy change could have would be tremendous. I think when we go back to that social ecological model, there isn't a answer. I mean, it has to be multi-layered interventions. I think the primary care providers we find to be very malleable and open, and they don't have, I think, some of the same biases that endocrinologists might have about the devices because they know less. And so we find an openness in the PCPs to implementing some things. I think it's actually endocrinologists in the adult setting and ped setting need to be part of trainings on implicit bias as well. So it has to be multi-layered, but I think one of the first most important things is just addressing policies related to cost and coverage of things like CGM and pump.
Do you guys provide e-consults, like for the providers if they have a specific question that is more
Yes.
urgent?
Yes, that's the real-time support with the medical hub team. And so that's where somebody like Mike Haller would jump on a call, sometimes with a patient in the room. You have to remember in the ECHO model, the hub team is not giving direct care. They're guiding the primary care provider how to make decisions, just like a resource you could utilize. But there's definitely in California and Florida, not just the endocrinologist, but our clinical health psychologist gets utilized a lot for just the help that's needed related to the challenges of living with diabetes and under-resourced FQHCs that don't always have a clinical health psychologist or access to that for their community. So yes, that definitely happens. That's where we gave out our cell phone numbers and we were a little nervous at first, but it's really been manageable and I think probably underutilized.
Are there any other questions in the chat?
There was one question in the room.
Yeah, I had a quick question. I think this model is so cool. And maybe this is a little bit out of the scope, but I thought I'd ask it anyway. Just in terms of like incentives, like outside of kind of a research setting, I'm curious, like, do you see this scaling up to be more of where like specialized care comes back to the primary care team? And if so, like what incentives do endocrinologists have to partake in this peer-to-peer education rather than retain kind of like patient populations? It's a little cynical, but like retain patient populations for themselves.
You're raising a really good point. So some of the initial pushback we got was from endocrinologists who are like, PCPs can't do this care. And so you definitely run the risk of stepping on the toes of some subspecialists that I think might initially feel that. But to be clear, in any iteration of Project ECHO, we don't want to replace a subspecialist. We want our PCPs to be making referrals. We want them to be doing that, but we know there has to be additional resources. This is like playing contact sports and you want more padding. And so the education is to augment what we hope they continue doing. So a lot of times it's just to assuage the fear of a subspecialist that we're like taking away a referral for you. So I think that that is what you're saying is not off base. It's not out of scope. That's actually a real thing that when you're starting to implement a program, you're going to hear pushback from subspecialists who worked long and hard to learn what they did, and they feel like they're the best. But I think there's also an enormous group of subspecialists in many different disciplines who recognize health disparities are profound and will do anything they can to try to help. The reality is you've got to buy out people's time in an academic medical center to serve on the hub team. If you have an MD that you're asking to attend the echo session, weigh in and do this, you have to buy out what's called some FTE, and that costs money in academic medical centers. I want to say there are examples of Project Echo models in other countries where you don't have FTEs and you don't have the grant people like volunteer to do this in a different kind of model, because they don't have the same constraints, I would say, as in an academic medical center. But that's a really good question, actually.
I got a question. With CGM, the data, and I think we're having this conversation, but wondering if you guys have explored with CGM, the impact on A1C is relatively modest. So adding technology may help lower your A1C by 0.2, 0.3%. But you're not seeing the other impacts in patients with type 1, which is problematic hypoglycemia, maybe a reduction in the chances of getting admitted with DKA, etc. But really now the standard of care for type 1 should probably be closed loop systems, AID or artificial pancreas, how we call it. Have the providers asked for this, for more training, or are they interested, or are they trying to help patients get this technology that actually makes a huge impact on the future?
Well, first I want to go back to the benefit of the CGM. So much in diabetes, there's a focus on HbA1c, but we know that we can't just focus on HbA1c. And I think one of the profound values of the CGM is just an enlightenment that happens when you have access to more data on how your behavior and what we eat impacts our blood sugars. And that is something that you can see more profoundly in color and, lots of different layers with the CGM. So I don't think it, even if it doesn't improve HbA1c the way we would like, which if you look at so many large clinical trials, it's hard to improve HbA1c. If you look at other things like someone's confidence in their ability to understand how to bolus based on what they're eating, I think the CGM can be really, really powerful just for understanding the enlightenment. But are the health centers wanting closed loop systems? We in the state of Florida, we are so far from that in the FQHC setting, just because just starting with the CGM, this is a new technology that many of the providers were not comfortable with and didn't know about. So I think that this is like a first step, but to get to the closed loop, there is many more steps that are going to have to happen. And I think still a lot we need to know and understand about closed loop systems before we would implement them with communities that sometimes get exploited in research. And so I think we still have a lot to learn before we would trial that in the FQHC setting for a number of different reasons.
Thank you so much.